All right, Chapter 9, Care of Patients with Common Environmental Emergencies. This chapter looks at environmental emergencies that we may see when we leave our home to enjoy recreational activities. Oh, I need to put it on. Sorry, guys, I need to put it on this. You're going to love me after all this. All right, so we're going to work on saving tissue integrity and having comfort in our patients when they may be experiencing pain. And we're going to work on illness and injury prevention strategies for nurses to incorporate into their own lifestyle and health teaching opportunities. So the first thing we're going to talk about is heat-related illnesses. Sorry, I needed to clear my throat. And this is for patients who have high environmental temperatures. Could be caused of heat-related illnesses along with high humidity. Patients who are at risk for heat-related illnesses include the older adults. Older adults have less body fluid volume and can easily become dehydrated when exposed to excessive heat and humidity. Those with mental health conditions, sometimes the medication lithiums and neuroleptics and anticholinergics plays a risk also. Those who work outside because they wear heavy clothing, sometimes a social disadvantage, they don't have air conditioning in their home. Homeless individuals, people who use illicit drugs, outdoor athletes who are training, along with the military stationed in hot climates. We need to know their health status also leads to heat-related illnesses such as obesity. The first heat-related illness we're going to talk about is heat exhaustion. You get this because you're dehydrated from heavy perspiration and inadequate fluid and electrolyte intake during heat exposure over hours to days. Patients may have flu-like symptoms, nausea, vomiting, muscle cramping, weakness, and a headache. Their body temperature may not change during this. So, symptoms can also include profuse diaphoresis and can lead to dehydration and hyponatremia. This can lead to a heat stroke. Treatment: we need to stop the activity they're doing and transfer our patient or client to a cool place. We want to rehydrate our patient with normal saline if they complain of nausea or vomiting. We need to draw blood to measure electrolytes, and we need to possibly admit them to the hospital. If they're having a heat stroke, is a true medical emergency. The body temperature may exceed over 104 degrees Fahrenheit. A high mortality rate without treatment. When we have a heat stroke, the patient's thermoregulation mechanisms fail and cannot adjust for a critical elevation in body temperature and can lead to organ dysfunction. There are two major types: exertional, which is a sudden onset, typically from strenuous physical activity in hot, humid conditions. And you might see this in runners. The next one we're going to see is non-exertional, which is a classic. When the temperature outside is hot, patients or clients occur over a period of time from chronic exposure to hot, humid environment. This is known as a classic heat stroke. We might see this in patients with homes without air conditioning. Mainly the ill and elderly patients end up with this in the emergency department. Symptoms can include mental status changes such as confusion, bizarre behaviors, seizures. They can become hypotensive, tachycardic, and tachypnea. The troponin level may become elevated because there's myocardial damage. If you look on page 134 in your book, it goes over key features of a heat stroke. Interventions for this: when we have a patient, we want to keep them NPO. We want to place our patient on oxygen, and we want to use our ABCs, airway, breathing, circulation. We want to start several IV lines of 0.9% saline and insert a urinary catheter. I would probably choose a temp sensing one. We want to cool our patient until the rectal or core temperature is 102 degrees. We can apply ice packs to the groin and axilla. We may use internal cooling, put them on a cooling system. There's like big patches you put on the front and back of the patient. When we're trying to cool them, though, we need to watch for Morgan's system organ dysfunction syndrome, and along with some electrolyte imbalances, and they might become hyponatremic. If the patient becomes to shiver, we could offer them diazepam or lorazepam, which is your benzodiazepines. They may have seizures, so we may also need to give another IV benzodiazepine, because when they have seizures, it elevates the body temperature. Sorry about. We're all surviving with our children home, and my daughter's favorite word is mom, so sorry about that. Alright, next topic is snake bites and arthropod bites and stings. On the left side of the screen is a southern copperhead. On the right side of the screen is a cottonmouth water moccasin. Both are venomous, and we're going to talk about these types of snakes that we see, that if we get a venomous bite, we need to know how to treat that in the emergency department. The picture on the left side of your screen is a coral snake, and we know that because it has the red and black rings separated by yellow rings on there. These snakes are usually found in North Carolina to Florida and the southwestern states. When they do a bite, you know that they might not always inject venom, but if you don't know what the kind of snake it is, if the snake cannot be positively identified, you want to treat as if venom has been injected. Venom can cause local and systemic toxic effects. Our popular nursing diagnosis for snake bites would be impaired tissue integrity. There's the assessment. Vesicles can form on the snake bite. We know that ideally we want to know the type and amount of venom injected and the bite location. We also need to know the age, the size, and the health status of the victim. So when the first responders call in and report, we need to know if they could guess a typical weight, the health status at the time and before the bite, and their age. Patients may experience severe pain, swelling, and redness or bruising, so you're going to treat that with pain medicine. Systemic effect, they can have a metallic taste. They can have tingling of the face and scalp, along with muscle twitching and weakness. When we're in the hospital, when we're also pre-hospital, we want to maintain the extremity at the level of the heart. Keep our patient warm. Do not cut on the wound. Don't try to open it. And do not apply ice to the site. Some people want to do that to help prevent the swelling. We show up to the hospital. This is a true medical emergency, so we need to insert 2 large bore IVs, such as 16 or 18 gauge. We're going to give some crystalloid fluid, such as normal saline or lactated ringers. We're going to get them on the cardiac monitor and blood pressure. We want to do an EKG to make sure they're not having a heart attack. When we get our lab work, the creatinine kinase will rise over time. We want to measure and record the circumference of the bite every 15 to 30 minutes. We want to mark the skin with the skin marker. If it is a pit viper, we can go give Crofab. It has IgG in it that binds and neutralizes the toxins and venoms. We're going to give this within 6 hours of the bite. Coral snakes don't destroy tissue, such as the pit viper, so you can apply pressure. There's no anti-venom available with coral snakes. You always need to contact poison control, and you always need to update their tetanus shot and give a tetanus vaccine. The next thing we're going to talk about is spiders, scorpions, bees, and wasps. And on table 9.2 on page 138 of your book has all of the answers. So we're going to talk about those. I'm going to turn over. This one has scorpion. I'll talk about that now, since the cute little diagrams there. So scorpions are found within the United States, most likely in southwestern part of the United States. And they use their venoms injected via their stinging apparatus on the tail. And the effects are neurotoxic. So we want to transport them to an acute care facility. They may complain of pain, burning, numbness. They could eventually become unconscious. We're going to monitor these patients, especially the older adult or those with cardiovascular disease, because it can lead to hypertension. They may begin to develop seizures due to the rapidly rising blood pressure. We're going to provide basic wound care and clean the wound and apply an ice pack to the sting site. We can administer analgesics, but we want to use caution so it doesn't lose their airway reflex and precipitate respiratory failure. Alright, the next one I'm going to talk about is the brown recluse spider. This is a medium-sized light brown fiddle-shaped mark from eyes and down their back. The venom can cause cellular damage and impair tissue integrity. We can apply a cold compress over the site of the bite. The central bite mark will appear as a bleb or vesicle with edema and erythema around the thing. The central part of the wound can become necrotic over 1 to 3 days for some patients. Antibiotics may be prescribed, and we're going to update their tetanus. If it's an extensive wound, we're going to debride it and skin graft may be needed. A black widow spider, its venom is also neurotoxic and can produce a syndrome known as lactrodectum, in which the venom causes neurotransmitter release from nerve terminals. And you apply an ice, sorry, my dog's barking. You're going to apply an ice pack to decrease the action of the neurotoxin. There's a tiny papule of small red puncture mark, and systemic complications usually develop within an hour of the bite. They can complain of abdominal pain, especially muscle rigidity and spasms. We're going to closely monitor our older adults. We can administer opioid pain medicine and muscle relaxants such as diazepam, also known as Valium. You want to monitor for signs and symptoms of anaphylaxis. Well, and both of those you need to contact poison control. And the next thing we're going to talk about is my little friend, the bee. Bees and wasps. Obviously, these are found all over the United States. Venom is injected through the stinger, and most can sting repeatedly when distributed. Only honeybees can sting just once. You can quickly remove the stinger with tweezers or gently scraping or brushing it off with the blade of a knife blade, credit card, or needle, and apply ice. With bees and wasps, we know lots of people that are probably allergic to them, so they need to carry an EpiPen with them. If they've had a history of swelling and respiratory distress, epinephrine must give immediately, and you give that IM, and you can give it through, like if patients out in the wild and they have pants on, they can give it straight through the pants. And on this picture, you can see the wheel and flare reaction, and it could involve the entire limb or body becoming swollen. It can have hives and itching. They can, if it's allergic to the bee sting, they can have swelling of the lip and tongue in patients. You want to monitor for anaphylaxis. That becomes a true medical emergency. When patients with bees and wasps, so if they show up to the emergency department, we're going to give them epinephrine if they haven't had it. We're going to give them protonics to kind of coat their stomach lining to prevent the nausea. We're also probably going to give a steroid such as salumedrol or Decadron. We're also going to give an antihistamine known as diphenhydramine or Benadryl. You also may give them the albuterol to help them breathe too. So if you have questions, let me know. Next thing we're going to talk about is lightning injuries. Lightning injuries are highly preventable, and these can happen year-round due to the forces of nature. They do lead to multiple injuries and death. It's caused by an electrical charge generated through thundercat clouds. The duration of contact is nearly instantaneously, resulting in a flashover phenomenon. You want to make sure they're not in water. The clothing and shoes of victims may be damaged or blown off when they get struck. Many survivors don't die, but they're left with permanent disabilities. These are preventable, so we can educate our patient to stay inside during an electrical storm. People like to go out and watch storms and drive around, especially when it's tornado season. All right, so the most lethal initial effect on these patients is cardiopulmonary system, and it can lead to cardiac arrest. And then eventually it may lead to respiratory arrest because it can produce hypoxia and subsequently lead to a second cardiac arrest. We want to begin, if they're under arrest, we want to begin CPR. So if they are breathing on their own but don't have a pulse, you need to start CPR. Or opposite, if they have a pulse but not breathing, then you need to give rescue breaths. The central nervous system injury is also common in lightning strikes. Typically, they have temporary paralysis that affect the lower limbs. They can also have cataracts and tympanic vein rupture. They can also experience depression and post-traumatic stress disorder. They also can develop skin burns and EKG arrhythmia, so we want to get an EKG on them right away. And their skin, as shown in this picture, can have Lichtenberg figures, and they're not considered burns, but they're thought to be caused by coagulation of blood cells in the capillaries when they get struck by lightning.